Normally I ask what everyone's had for breakfast, but as we're in lunchtime now, I'll postpone that question. Well, look, we'll give it another 30 seconds or so while everyone comes in, and then we will kick off. So for those who are joining us, welcome, and great to have you on the webinar. We've got an exciting 30 minutes ahead of us, but let's give it another 30 seconds or so. Great. Okay. Well, look, why don't we start? The time has come, and I think it's important we stick to time. So firstly, let me extend a welcome to all colleagues, both as panel members and members of the audience who have joined us this afternoon for a webinar where we will be looking and discussing at the advancing of digital first delivery of care with Huma and myGP. My name is Dr. Harpreet Sood. I'm a GP and also I work at Huma as part of the clinical team there, and have the pleasure of introducing this afternoon our three guest panelists. We have Dr. Kuldhir Johal, who is a GP from London and works in the ICS there. We have Dan Vhadat, who's the CEO and founder of Huma, and we have Tobias Alpsten of myGP. Welcome to you all. So like I said, we're very excited to have you all here, and we're going to be talking about this afternoon on what we can do with Huma and myGP as part of the services that we have available, and how it's being received in the NHS today and the wider community, and what the availability of expansion of our services will be as we look forward to the opportunities in front of us. It's certainly been an exciting time for technology in general practice, and we've seen the acceleration of that over the last 2 years in particular. And I think it presents many more opportunities as we look ahead. And so really excited to hear from the front line of what Kuldhir has been doing, from Tobias on the myGP app, which has had a number of people downloading it, using it, and from Dan talking about the technology that Huma can bring and how we bring it all together. As my job, I'll be keeping the panelists to time, and so it'll be important that we stick to that. But if you do have questions at the end, which we will have time for, please make sure you put them in the Q&A box, and I'll be monitoring them throughout and asking the questions at the end. So without further ado, let me pass over to Dan, who will kick off on giving an overview of Huma, and then I'll bring in Tobias. Dan, over to you.
Perfect. Thank you so much. I'm going to share my slides. Harpreet, let me know if you can see it.
Yeah, perfect, Dan.
Perfect. Welcome everyone to one of our webinars today. I think the aim of what we want to achieve together as a collective group of obviously all the members of our community and the ecosystem we have built, to see how we can bring digital first care at a scale, and talk a little bit about what we have done so far with the ecosystem of the companies that are part of Huma family, covering in London area alone 499 hospitals, clinics, GP surgeries. By doing that, ultimately increasing the impact and the access of care for all the citizens in London, but obviously the same model is applicable for the entire UK and globally. With that background, I wanted to talk a little bit about what Huma is up to in a very numeric way, number-driven, and some of the impacts that we are excited. And we think this is just the beginning. As you all know, Huma started almost 10 years ago with one mission: to bring digital first care to hands of as many people possible in every country, powering hospitals at home and virtual wards at the scales that perhaps historically we couldn't even imagine. And to be able to do that, we built these modular platforms to look after patients with different conditions. And the idea is, as you have a condition, you get prescription of a application, and the applications helps you to navigate your disease, connects you to the care providers, nurses, doctors, and so on and so forth. And by doing that, you can receive most of your care at home proactively and hopefully avoid some of the complications, readmissions, and so on that can be very expensive for the healthcare systems, but also quite uncomfortable for the patients. Now, 10 years later, from our vision and our dream when we started, we are really proud to power on the back of the trust of amazing partners like NHS, government of different countries from Germany, France, and others to support some of the world's largest initiatives. One of our most recent tenders in France, as you might know, is covering 1,000 plus hospitals. And by doing that, impacting many, many patients, perhaps one of the largest deployments that you can imagine in terms of the number of patients, but also the scale of the operations that we had to deliver. As you know, for some of the conditions, you can't only rely on the phone, you need to have sensors, devices, and hence we, as a company, we have shipped over 1 million devices in support of collecting data and kind of almost bringing a mini hospitals of sensors to your home so that the care delivery can happen all remotely and in a very proactive and predictive way. When we launch digital solutions and when we want to support patients and clinicians and care providers, very important to focus on simplicity and design and make it in a way that people can use it and benefit from it. And these are, again, some of the stats from our recent deployments in terms of the user adherence. And the most important metrics here is 38% of the patients cohort are between 60 to 80 years old. And this is something that's very important for us because 10 years ago when we started, one of the big concerns was, can elderly people use technology? And I think that somehow addresses it. And we know that in the next 10 years, things is going to only get better and better. And again, this is a very, I guess, meaningful testimonial of one of our patients in one of our national projects, talking about how they see an applications on their phone. What is the impact of an app in their life? And I think this is just the beginning of the trend of digital health technologies that can impact patients' lives. But more importantly, as great and as excited we are to power patients, we have to launch solutions and leverage technology and ecosystem of partners to deliver outcomes to healthcare systems. And again, some of the audits and initiatives that we have started publishing, it shows a digital technology that can sit on a patient's phone that can basically empower and enable almost everyone that has a smartphone, which is a really growing populations, help suddenly a country, a region, a healthcare systems double their capacity. So by same number of users and resources and doctors, potentially look after twice more patients. And not only doing the monitoring, but also being able to reduce things that are very expensive for healthcare systems, like readmissions as an example, things that can go really wrong and can be very painful. And that's kind of the dream of what Huma is all about. And this is why we partnered with myGP and brought them to our family, the Tobias teams and the rest of the ecosystems to be able to do what we are doing even better and in a larger scale.
Brilliant. Thank you very much, Dan. Let's, on that basis, thank you for the introduction. I think it's fantastic to hear about the progress Huma's made. And now let me turn over to Tobias to bring in about the myGP app and how iPLATO has come into the family of the Huma and how we can do more together. Tobias.
That's right. Thanks. I mean, so the theme here, as Dan outlined, is just to create ecosystems to improve outcomes, extend life and life expectancy. We are iPLATO and myGP, the two brands that you may have heard of, are slightly older than Huma. So if you imagine, we started already before the iPhone came out, when people didn't access the internet on their phones and didn't use apps. Natural communication method then was text messaging, and so and that's where we started. So the first phase of iPLATO, very much about patient engagement. We do that in many different ways, but and today we of course tag along web apps and we tag along apps. We do our questionnaires and all of these things, but fundamentally, at GP level alone, we do cover 28 million patients in the UK. If you overlay that with the population-wide services we do, we can run population engagement campaigns around health for more than half of the country within hours, subject to GP approval, because we always partner with the primary care systems. The goals, the outcomes we try to achieve. Recently, we have evidence coming out of London. We almost doubled the uptake of diabetes prevention services. We're adding 25,000 women a year to cervical screening in London, and we've transformed uptake of mental health services in other parts of London. So we know how to deploy digital solutions in multiple facets to achieve patient engagement outcomes at almost any level in the country. So that was the first phase of this. Second phase, and this is maybe 5-6 years old, is a digital front door technology, and that is the brand you see here. Digital front door technologies or apps are very much about improving access to GP services, improving access to pharmacy services and medicines, improving access to specialists as well. And also what we do on myGP is assisted self-care to try to get people or help patients track vital signs in various forms. And again, numbers are pretty impressive. I suppose 2.5 million people use myGP today. Brings us to the third generation of tech that we are involved in, slightly younger, and that's the whole digital GP agenda, where we actually bring consultations into the app and online, and triage and care navigation. For all this time we've been doing this, so probably at least 5-6 years, our CCG customers and our NHS partners have asked us can we not do remote patient monitoring too? And that's where the iPLATO Huma partnership relationship comes from. It's just such an attractive thing to add behind, certainly, or alongside a patient front door or digital front door solution. So that's why we've made the tie up to be able to offer our NHS partner a fuller and better service that sort of underpins the whole patient pathway.
Brilliant. Fantastic, Tobias. Really, really insightful, and we'll come into a bit more of that detail when we get to the Q&A. Now, none of this, what we have also here today with us is Kuldhir, who's kind of been at the front lines using both technologies, Huma and myGP, and it would be fantastic to hear from her experiences of, from someone delivering this on the front line, what it has been like from your perspective as a GP in Northwest London. And we have your slides up here as well, which we'll go through. So over to Kuldhir.
Thank you. And thank you very much for the opportunity of taking part in the webinar today and sharing our experiences. I guess the real challenge for all of us is how can we truly harness what we have actually learned over the last couple of years using technology on a daily basis, so it does indeed become business as usual. And in my role, I'm a frontline GP. I'm very much a clinical IT lead across Northwest London and work with the London Ambulance Service across London, but also done a lot of shared learning at both national levels as well. Next slide, please. Thank you. So in this slide, what I'd like to do is bring it back into the context of our journey over the last couple of years. And it is about a collaboration of like-minded individuals coming together, and it's an excellent example of true integration across the whole system, which actually has gone on to win national awards, both in the NHS and the private sector, in relation to the work we've done with Huma, as well as local GPs, local hospitals, local emergency departments, and bringing it all together with the patient being at the centre. And it is about sharing all of that information from the onset and continued learning of insights across the country, but also internationally. So what happens in Northwest London? We're a patient population of about 2.4 million. And as you will see in the first figure, we've been recording all of the positive cases across London. Actually, actually across London, but you see a lot of Northwest London patients actually populate different parts of London. But more critically, over 500,000 patients have tested positive to COVID to date. That's almost 1 in 4, 1 in 5 of our local patient population, as noticed in the first figure across the whole system. The second figure, interesting enough, because we've continued to do the monitoring, gives you a good indication of how many patients are currently being monitored in the remote area in primary care alone. Just at the beginning of this week, we're still at about 1,700 in relation to COVID patients, and these would be the higher risk patients. Now, what have we learned about COVID over time? Well, as you'll all know from the timeline I've indicated at the bottom, it's about a new condition. It's Alpha, Delta, and even just a few weeks ago, Omicron and how it peaked, as well as all of the interactions and changes that have occurred in relation to the clinical pathways with the vaccination programs coming on board, us learning about who are high-risk patients and who need more monitoring, but equally with antivirals coming on board in the last few weeks, let alone. And therefore, the information we're gathering is not just at an individual user level in relation to their symptoms, but it's also about how that changes over time. And I think this is a brilliant example of a condition none of us knew anything about, but we've managed to learn as we've gone along over the last couple of years. And even in September 2020, we were very much involved in the understanding what is the information available, what are the thresholds, what are the right thresholds for escalating care. And working with Huma, we managed to pull the data down, share it with NHS Digital, and be part of the national evaluation, which therefore informed evidence-based medicine. And that's the uniqueness of what we're now saying is different for the primary care offer. It's real-time evidence-based going forwards. And as everybody will remember, at that time, it was about how do we work differently in primary care, because it was a big change from being saying in the community setting, can you monitor some patients with acute illness? And as a lot of you will recall, we were all scared. You know, it was a new condition, hot sites came into being, cold sites came into being. But even with really strict governance and processes in place, back in April 2020, within 3 weeks, we went live to onboarding our first patient, which in itself is now recognized as a digital record within the NHS. Next slide, please. So it goes back to what can we do differently? It's the basic concept of we had the pulse oximeter. Remember, we've got pen and paper. People were making notes of diaries. But it was about how do you enable that as an interaction. So in our model, it didn't matter whether you did or didn't have an app. It was about managing the whole process and the system. But what we did understand by using the app, it was about how you can then collate the information into a dashboard. The dashboard is really critical to me as a clinician because what we managed to do was put thresholds in place in relation to rating red, amber, green. Those thresholds would change over time, which was the uniqueness of this feature. But more critically, you can manage a lot more patients and then prioritize the patients depending on their clinical individual needs and contact them in a real time. And one of the key findings was, for example, with the Huma app, if a clinical record is reviewed, just as people will be familiar with WhatsApp, you get a double tick. Patients knew intuitively that somebody was looking at their information, and it gave them confidence, and the confidence has continued. Next slide, please. So the real challenge for all of us is how do we change this? We're talking about remote monitoring systems. It's about a managed service. And how is this changing the landscape? And what I've tried to do is really simplifies the complexity of the whole landscape. The key principle we've all learned is patient information is key. Getting the right leaflets in place. So through COVID, we've got a national leaflet, which if those of you are familiar will realize we're already on to version 6 or 7, but it has evolved over time. It's about the consistency of approach, so we're all using the same information. I've indicated in yellow the two interactions that we're already familiar with in our GP interactions as clinicians and patients, use of the telephone. But by using the digital app, you can make it a two-way conversation without necessarily picking up the phone. And I've already indicated to make sure it's equitable to everyone, it is about making sure your remote monitoring system actually complements and enables as many patients to contact as possible. But as I've already indicated, the digital tools used allow you to use a dashboard which then interacts within GP systems going forwards. But the new challenge for all of us is how do you make this become business as usual? You'll see in my slide right at the corner at the bottom is the green bit saying personalized care. Historically, this is always about personalized care plans being either in outpatients or as an inpatient, but actually this is the uniqueness, is about making it the whole patient the whole time. And that's a game changer in itself. So what we managed to demonstrate was we can do this at speed. We can do this in relation to urgency. It's about the collaboration, understanding the guidelines, etc. Next slide, please. So here is our evidence base in relation to what happens in relation to COVID across Northwest London. We're probably one of the few unique areas where we've managed to keep it going for the last 2 years, and now we're in the process of, fingers crossed, changing because the numbers of COVID cases are going down. But the principles of what we've learned is key and continues. And the principles are actually the right safety net information by all parties involved. So we're giving consistently the same message, even within the London Ambulance Service. They were using the same patient information leaflet. The maternity services were using the same one. And that's the uniqueness about how we managed to adopt it from the national and feed onwards and upwards. Again, here it's about engaging and empowering the individual patient, but also empowering the clinician so they can manage their time better as well. And as a key part of that, there's been a number of studies that have indicated the productivity and the efficiency savings that can be made as a result of using these technologies. Guess what? This has gone on to inform national policy. And we know in relation to the national guidance that came out around just before Christmas, yes, on Christmas Eve of all days, it was about how you can look at within an ICS, almost 15% of your bed base can be in a virtual setting. This is a game changer, and it's a question how we harness this going forwards. Next slide, please. So here are the challenges. How can we make this different in the new world? And how can we adopt it so it becomes mainstay? I've given an example of high blood pressure, which most people will know as hypertension. It's a long-term condition. But I just want to remind people, it's not about the disease, it's about the individual patient and the different disease entities that may be involved for those patients. As I'm sure a lot of you will be aware, even now we recognize there's almost 5 million adults who have got undiagnosed high blood pressure. In addition, we know there's 8.4 million adults who are diagnosed with high blood pressure, but less than 50% of them have optimized blood pressure. What we also already know is that 50% of strokes and heart disease are associated with uncontrolled blood pressure. So you can see something that we all already do on a day-to-day basis can become influenced by how we can use digital technologies going forward. And more critically, next slide, please. Thank you. And this just demonstrates how we can bring it all together. It is about making sure we use the digital technologies currently available and the interactions between those digital technologies. Of an indication of the NHS app, we know about 25 million individuals across the country already have access through that. And that in itself is a gateway through to myGP, but it's about making the interactions work. I'll stop there and open it up to questions, but I hope that's been informative. Thank you.
Thank you, Kuldhir. Very informative and fantastic to see how this is rolled out in the community, the use of evidence and how you are thinking about pathway redesign. And that's a lot of the things that we would want to focus on. I know you're conscious of time and I know you need to rush off at one. So, using the chair's prerogative, let me start firstly with you. You've given us a very good view from patients and kind of the things you've done in terms of setting this up. What I want to know, and I think the audience will also want to know, is how has this then helped clinicians in terms of increasing clinical capacity, but also the experience from clinicians as well?
So what we've learned is that, for example, what I've tried to indicate is what's occurring at the population basis, but also at a higher end of, if you're doing remote monitoring, you build up a skill set of clinicians. and you also work interactively across those clinicians. So it isn't about necessarily working differently. It's working in a uniform way as a team. We have clear pathways in place, and the digital technologies enable those pathways to be delivered in a timely manner. And the time factor was a critical factor in relation to COVID initially, because if a patient deteriorated within 24 hours, you wanted to escalate their care sooner rather than later. But the lessons that we've learned is that you may find there's certain thresholds you want to do going forwards, for example, in primary care networks, where as networked teams, you then want to manage different caseloads and patients going forwards. The game changer for us in relation to Northwest London is it meant that even though all systems were under pressure, including primary care, you manage the time differently. And I think that's going to be the challenge for all of us going forward is how do you recognize that time and value? Because it does save time. And that is a challenge for finance officers at this moment in time, showing the evidence base and the value for money.
Brilliant. No, that's absolutely the case.
I mean, the key message here was it saved lives. We know from the quality point of view, it absolutely was a game changer because it changed the national thresholds.
No, absolutely, and I think it's how do we bring those both worlds together? I mean, as you can see, I'm also beaming in from a GP practice at the moment, and this is often the challenges that we have: is that how do we think about the managing demand, but also improving outcomes? Fantastic. There's a question that's come in the chat, and I think this is probably for Tobias and Dan. The question from Ariel Cohen is: how does the iPLATO app differ from Huma's, and how do they complement each other? Dan, Tobias, who wants to go first?
Sure, I'm happy to
go for it, Dan.
I think from our side, Huma is all about as soon as you're diagnosed with a condition, you get a prescription of an applications for that conditions, and you've been looked after for that case, right? COVID is a good example that we talked about, hypertensions and a range of diseases. And myGP iPLATO, the work that Tobias does, is actually engaging with everyone, making sure that everyone's population health is in a good place proactively. And then if someone gets flagged and then get diagnosed for that condition, this is where Huma comes. So together, we are actually looking after the population when you go through your primary care, and then afterward, either you be monitored via primary care setup or sometimes through the secondary care in case your condition is more critical. That's kind of the beauty of it. And hence why we wanted to partner and join forces with iPLATO team and bring them under Huma family, so we can be actually deliver more coverage to the populations in the UK.
Fantastic, brilliant. And Kuldhir has added managed clinical care in the chat. I'm assuming you're referring to this question, Kuldhir. Yes. Brilliant.
Yes, because I think as a clinician, and in the GP system, you get individual patient records, for example. In the secondary care system, and as part of the clinical dashboard that Huma had to offer, you got the overview in priority, and you could automatically prioritize which patients needed to be contacted sooner rather than later. That absolutely meant that you weren't looking for the needle in the haystack. You were managing it dependent on clinical need at that moment in time. That's the game changer to me.
Fantastic, Kuldhir, and absolutely agree on that. Okay, conscious of time, but I think we can squeeze in one final question. This one's to Tobias, which is, through your work with myGP app, how have you seen how patients are managing their own health with this technology?
Well, we do see engagement, and clearly what there's evidence for this. And if you, for example, we come back to blood pressure here, patients who keep track of their blood pressure, they do manage their health better than those who don't. And so to bring these assisted self-care tools is really the first bastion. It just costs us nothing really to support that process, and yet it delivers outcomes. And we have 70,000 people who do that on our app today. It's a feature, a widget on the app, and it just happens, right? So it's engagement and assisted self-care support is something we can provide at almost no cost to the population at large, and that's valuable. But clearly, eventually, and what we do see, the power of clinicians and the power of GPs in our case, the moment a patient thinks that their doctor is watching, adherence goes up, engagement goes up, everything happens. So we do think of it as a hybrid world. Digital will not do all of it. We need this clinical expertise to work, but we need to, clearly there is not enough clinicians to support the healthcare demand as it grows over time. So we need to find ways of, augmenting the clinical experience with digital, and that's really what we're seeing.
Yeah, fantastic. Thank you, Tobias. Kuldhir, I know you need to go, so thank you very much for joining us this afternoon and giving your frontline experiences. I hope that's been helpful to everyone that dialed in, but good luck for your next webinar, and we'll see you soon.
Thank you. Bye.
Bye-bye. I know we said it was the last question, but I just feel that we can squeeze one more. So those that need to sign off, please do, but those that can stay, I just wanted to put one more question to both Dan and Tobias, which has also been put forward by George Godfrey, who's mentioned that one of the challenges to adopting novel tech at scale is not only showing improved outcomes, but also that you can save clinical and patient time in the management of long-term conditions. Please, can we comment on the aspects in terms of evidence? And I know Kuldhir mentioned some of this in her talk, but if any of you wanted to just pick up, because I know that comes up time and time again, and I think it's important that we address this. So Tobias or Dan, who would like to go first on that?
Let me go first. Dan can definitely add to this because your research resources are significantly greater, but we have spent a long time pushing for digital health is traditionally evidence poor. And one of the reasons for that is that the timelines don't match. So if I was to deliver a new drug, I might have the decade that it takes to do the research, do the trials, write up the trials and publish it. But in digital, we develop apps in a couple of weeks. So the timelines don't fit very well, but we have spent a lot of time, particularly on cancer screening, to see how, very often using behavioral economics, nudge theory, to see what kind of messages that reaches out, what kind of, because this is about behavior, and that can be researched. So we've definitely promoted and partnered with Imperial and UCL and a number of the academic institutions in London and elsewhere to achieve that. And I think that's something we have in common.
To build on what Tobias mentioned, the beauty of technology is quite scalable, and then suddenly you can have the kind of supervisions that otherwise would have costed thousands of pounds per day for a patient now in a matter of almost no cost in home of everyone. And by doing that, obviously, these are some of the stats that we have published through some of our national or regional projects. You can easily, like, for some conditions, obviously digital is not the solutions for every conditions, but there are some conditions that digital care and digital first delivery of care makes sense, suddenly double the number of patients you can look after. That was kind of some of the stats that Kuldhir was talking about, or reduce the readmission of those patients by 30%, which is a massive number when you look at the cost of each readmissions, ignoring the fact that sometimes by the time that you get the readmissions, it might be actually too late for the patients. So the impact and the stress to the family and to the patient itself. Or in the case of surgeries, that's another area that we are doing a lot of activity, reprioritizing patients for their surgery time by a significant magnitude of those number of patients that you're booked for, like, let's say 6 months from now for your heart failure or your cardiac surgery. Something is not going well, you're deteriorating, then they can reprioritize you. And then the patient that is doing better kind of like move backward in that line. So by simple things like that, not only you save lives, but more importantly, you actually save a lot of time and cost. And these are all published, and we have lots of those, and a lot more actually coming.
Brilliant. Thank you, Dan. So look, I'm going to have to make a close there. I'm apologizing. I've eaten 6 minutes into people's lunches, so I owe you. So next time I ever see any of you, please ask me for that time back if I can give it to you. But thank you very much for everyone joining this afternoon. I think it's been a very rich discussion. We've heard from all three speakers, Dan, Tobias, and Kuldhir, in the app, myGP, we've heard about Huma's technology, but we've also heard from frontline GP who's actually been implementing this in a real world setting. And I think it's really important to have those perspectives. Please get in touch. Any questions you may have, any demos, any question, do get in touch. The email is up on the screen now. And again, I just want to extend a big thank you to everyone who's joined, but in particular to all our speakers. Have a good afternoon.